Heart failure. Heart failure, also called congestive heart failure, is a clinical syndrome that results from heart's inability to pump the amount of oxygenated blood necessary to meet the metabolic requirements of the body. Pathophysiology and etiology. Number 1. Cardiac compensatory mechanisms, that is, increases in heart rate, vasoconstriction, heart enlargement occur to assist the failing heart. These mechanisms are able to compensate for the heart's inability to pump effectively and maintain sufficient blood flow to organs and tissue at rest. Physiologic stressors that increase the workload of the heart, exercise, infection, and may cause these mechanisms to fail and precipitate the clinical syndrome associated with the failing heart, that is, elevated ventricular and atrial pressures, sodium and water retention, decreased cardiac output, circulatory and pulmonary congestion. The compensatory mechanisms may hasten the onset of failure because they increase afterload and cardiac work. Number 2, caused by disorders of heart muscle resting in decreased contractile properties of the heart. Coronary heart disease leading to myocardial infarction, hypertension, valvular heart disease, congenital heart disease, cardiomyopathies, and dysarrhythmias. Number 3, other causes include pulmonary embolism, chronic lung disease, hemorrhage and anemia, anesthesia and surgery, transfusions or infusions, increased body demands, fever, infection, pregnancy, arteriovenous fistula, drug induced, physical and emotional stress, excessive sodium intake. Clinical manifestations. Initially, there may be isolated left ventricular failure, but in time the right ventricle fails because of the additional workload. Combined left and right failure, right ventricular failure is common. Left-sided heart failure. This is also called forward failure. Congestion occurs mainly in the lungs from backing up of blood into pulmonary veins and capillaries. Shortness of breath, dyspnea on exertion, paroxysmal nocturnal dyspnea due to reabsorption of dependent edema that has developed during day, orthopnea, pulmonary edema. Cough may be dry and productive, often occurs at night. Fatigability from low cardiac output, nocturia, insomnia, dyspnea, catabolic effect of chronic failure. Insomnia, restlessness, tachycardia, S3 ventricular gallop. In right-sided heart failure, that is also called backward failure, signs and symptoms of elevated pressures and congestion in systemic veins and capillaries. Edema of ankles, unexplained weight gain, pitting edema is obvious only after retention of at least 4.5 kg of fluid. Liver congestion may produce upper abdominal pain, distended neck veins, abnormal fluid in body cavities, pleural space, abdominal cavity, anorexia and nausea from hepatic and visceral engorgement. Nocturia, diuresis occurs at night with rest and improved cardiac output. Weakness. Cardiovascular findings in both types. First one is cardiomegaly, enlargement of the heart, detected by physical examination and chest X-ray. Number 2, ventricular gallop, evident on auscultation and ECG. Number 3, rapid heart rate. Number 4, development of pulsus alternus, alteration in strength of beat. Diagnostic evaluation. ECG may show ventricular hypertrophy and strain. Echocardiography may show ventricular hypertrophy, dilation of chambers, and abnormal wall motion. Chest X-ray may show cardiomegaly, pleural effusion, and vascular congestion. ABG studies may show hypoxemia due to pulmonary vascular congestion. Liver function studies may be altered because of hepatic congestion. The assessment, we have to assess for obtain history of symptoms, limits of activity and response to rest. Second, assess peripheral arterial pulses, note quality, character, assess heart and blood pressure, rhythm and rate. Inspect, palpate pericardium for lateral displacement of point of maximum impulse. Last one, identify sleeping patterns and sleep aids commonly used by patient. These are all nursing assessments. Management. Treatment is directed at eliminating excessive accumulation of body water, increasing the force and efficiency of myocardial contraction, and reducing the workload of the heart. These goals are achieved through promoting rest and administering pharmacologic agents. Diuretics. Number 1. Eliminate excess body water and decrease ventricular pressures. Number 2. A low sodium diet and fluid restriction complement this therapy. Number 3. Some diuretics may have slight venodilator properties. Positive inotropic agents. Number 1. Increase the heart's ability to pump more effectively by improving the contractile force of the muscle. Number 2. Digoxin may only be effective in severe cases of failure. Number 3. Dopamine also improves renal blood flow in low dose range. Number 4. Dobutamine. Number 5. Milrinone, Primacor and Amrinone, Inocor are potent vasodilators. Milrinone, Milrinone, Milrinone or Primacor, Primacor. And second one is Amrinone or Inocor, Amrinone, Amrinone, Inocor, Inocor. Inocor. Vasodilator therapy decreases the workload of the heart by dilating peripheral vessels. By relaxing capacitance vessels, veins and venules. Vasodilators reduce ventricular filling pressures, preload and volumes. By relaxing resistance vessels, arterioles, vasodilators can reduce impedance to left ventricular ejection and improve stroke volume. Number 4. Vasodilators used in congestive heart failure, CHF, nitrates such as nitroglycerin, tridyl, isosorbide, dinitrate, asordyl, nitroglycerin ointment, nitrobid, predominantly dilate systemic veins. Hydralazine, aprisolene, predominantly affects arterioles, reduces arteriolar tone. Number 3. Prazosin, minipress, balanced effects on both arterial and venous circulation. And 4th, sodium nitroprusside, nipride, predominantly affects arterioles. Number 5. Morphine sulfate, decreases venous return, decreases pain and anxiety and thus cardiac work. Angiotensin converting enzyme inhibitors, ACE, inhibit the adverse effects of angiotensin II, potent vasoconstrictor. Decreases left ventricular afterload with a subsequent decrease in heart rate associated with heart failure, thereby reducing the workload of the heart and increasing cardiac output. Captopril and enalapril are commonly used. Beta-adrenergic blocking agents decrease myocardial workload and protect against fatal dysarrhythmias by blocking norepinephrine effect of the sympathetic nervous system. Metoprolol or lopressor are commonly used. Carvedilol is the non-selective beta and alpha blocking agent. Patients may actually experience increase in general malaise for 2 to 3 week period while they adjust the medication. Diet: restricted sodium, restricted fluids. High serum sodium levels are the most common finding in patients readmitted with the diagnosis of congestive heart failure. And the heart transplantation is the last one used in advanced heart failure. The complications, first one, intractable or refractory heart failure becomes patients progressively refractory to therapy, does not yield to treatment. Second, cardiac dysarrhythmias. Third, myocardial failure. Fourth, digital toxicity from decreased renal function, potassium depletion, and so forth. Fifth, pulmonary infarction, pneumonia, emboli. So, medical treatment, once again, low sodium diet, fluid restriction, and diuretics. Inotropic agents, digoxin, dopamine, dobutamine, milrinone. Vasodilator therapy, nitrates, nitroglycerin, hydralazine, prazosin or minipras, sodium nitroprusside, morphine sulfate. Angiotensin converting enzyme inhibitors, captopril. And beta adrenergic blocking agents, metoprolol, carvedilol. Thank you.